البداية بشكر organizing committee of this prestigious meeting, and I'm glad to be here this morning. الحقيقة أنا هحاول أعرض وجهة النظر الأخرى إنه sometimes why we shouldn't consider ad hoc PCI in some patients with multi-vessel disease, although most of the data is supporting more an index hospitalization rather than ad hoc. So this is a male patient. He's 64 years old. He's a smoker. He presented to the emergency room 11:30 a.m. with acute chest pain of 1.5 hours duration. He had free past medical and surgical history. His ECG showed inferior ST elevation myocardial infarction. On presentation, his blood pressure was 110/70, heart rate was 80 beats per minute, and the rest of examination was unremarkable. Angiography was done. Actually, he came in a suitable time, in a daytime. We were prepared. Had his left system injection. He had a lesion in the LED and another tight lesion in a large obtuse marginal 1. Then we injected his right coronary. He had another tight lesion with STEMI 2 to 3 flow in the RCA, which is a big artery. And actually, we had like 2 lesions in the obtuse margin and RCA, and for a while we were disputing which is responsible, but we ended like the RCA is the culprit artery. It had a TEMI 2 to 3, and it has a very tight and a rather long lesion than the discrete lesion in the obtuse marginal branch. So we started in his right coronary. We had to predilate with 1.5 millimeter balloon by 15. Then we introduced the stent. We had a drug-eluting stent, 3.5 by 18. We have inflated it to 16 atmosphere. We had some resistance here in the middle of the lesion. Sorry. في مشكلة. Okay, خلاص. We had TEMI 3 flow in the RCA with a good flow. So at this point, we were considering the following options: discharge from hospital and schedule next appointment for LCX and LED, discharge from cath lab, then PCI to LCX and LED before hospital discharge, discharge from hospital, then follow up for symptom pattern as per guidelines, or discharge from hospital, then do some non-invasive assessment for residual ischemia, considering that we don't have FFR to evaluate the function significance of the other lesions, although that it looked significant by eyeballing, and we used only contrast volume of 100 cc. So actually, due to simplicity of the other 2 lesions, they look like 2 lesions that can go by direct stenting. We had very short procedure. He presented early. The patient was stable. Actually, he considered the option of doing ad hoc PCI. At this time, actually, early on in 2014, the European guidelines consider primary PCI should be limited to culprit vessel, with the exception of cardiogenic shock and persistent ischemia after PCI of the supposed culprit lesion. This is not the situation. American guidelines considered ad hoc PCI as a harmful procedure, so it should not be done. As my Dr. Hani presented, we had several trials at this time: PRAMI, culprit, Dynamic 3, Pri-Multi, and Compare Acute, which has stated that completeness of revascularization is vital. I will not go through because Dr. Hani already explained some of this, but actually these 3 trials made a paradigm shift. As we see here in the culprit, there was almost 55% relative risk reduction of the composite endpoints in favor of complete revascularization, considering mortality and the need for revascularization. Likewise, in the NAMI-3 trial, also there was an edge for multi-vessel stenting compared to culprit vessel, and most of these were mainly in terms of reduction in the need for revascularization rather than reduction of cardiovascular mortality or reinfarction. So at this time, there was a revisit for the guidelines, which has put a PCI of a non-infarct artery may be considered in selected patients with STEMI and multi-vessel disease who are hemodynamically stable, either at the time of primary PCI or as planned staged procedure, which has had a 2B level of evidence B. And actually, this was the case of my patient. So I started by the obtuse marginal branch. We have put here a drug-eluting stent. It was inflated. This was at 2.75 by 24. It was put at 14 atmosphere. Then the proximal part was post-dilated by a non-compliant balloon, 3.25 by 14 at 16 atmosphere. As we see, with good angiographic outcome. Then this is the LED. It was measured, a direct stent, 2.5 by 30 at 16 atmosphere. It was deployed. Again, we had good flow in the LED. Let me say that this procedure, a total contrast of 180 cc, with 15 more minutes were added in order to accomplish both the obtuse marginal branch and the LED. So we did not use much contrast in addition to the previous one, and also the procedure was not a lengthy one, only 15 more minutes in addition to the culprit artery. What are the potential pitfalls of the unconditioned multi-vessel PCI approach? The severity of non-culprit lesion at the time of acute angiography may be visually overestimated, or a vasospastic narrowing which is no longer present at control angiography may be present weeks later. Complications associated with indiscriminate PCI of the non-culprit lesion, dissection, no reflow, acute stent thrombosis may lead to worse outcome. Finally, there is an increased risk of contrast-induced nephropathy. That is why the 2017 ESC guideline for the management of acute myocardial infarction in patients presenting with ST elevation, they have stated that routine revascularization of non-infarct-related lesions should be considered in STEMI patients with multi-vessel disease before hospital discharge, and it had 2A level of evidence A. So my final words here to conclude: STEMI with multi-vessel coronary artery disease is common, it's 50%. Complete revascularization should always be aimed for. The tenuous balance is between 3 more and 3 less. 3 more, it's more dye, more radiation, and more harm, and that 3 less ischemia, less repeat revascularization, and less MACEs. Non-infarct-related artery vascularization should be considered in STEMI during index hospitalization. However, to do in the index procedure or before hospital discharge remains to be investigated, so stay tuned. Thank you very much.